G'day everyone. Welcome to our UCLIC research seminars session today. Today we're lucky to have Talya Porat visit us from Imperial. She's an amazing researcher. And so it's really good to have her here, and she's going to be presenting her research, and I'll turn the time over to you now.
Yeah, I'm laughing because he said, how should I present you? And I said, just say I'm amazing. So he actually did it. Okay, hi, I'm Talya Porat. I'm a senior lecturer at the Dyson School of Design Engineering at Imperial, and very happy to be here. And really, it's just kind of an informal, just presenting our work. And hopefully there are a lot of kind of shared interest, and we're doing very similar things so we can learn from each other and talk a bit. I called it human-centered design in healthcare. It's very general, just mainly talking about different projects we do and kind of the process and the challenges we have, so we can see if we have similar things in common. So yeah, my background is human factors, human-computer interaction, cognitive engineering, and of course, mainly in the healthcare domain. So really trying to design interventions that are, of course, accessible and acceptable by users, with the main goal to improve patient outcomes. So this is our group, human factors. Sorry, is this better like that? Human factors in healthcare. And we're actually trying to understand and learn what decisions, how people make decisions in a specific context. What are the motivations? What are their behavior to really design interventions to improve those decisions, to enhance decision-making, inform decision-making, change behaviors, and as I said, improve patient outcomes. So we mainly are focusing on designing decision support and healthcare interventions for healthcare professionals, like diagnostic decision support systems and visualization. So how can we visualize data holistically to help healthcare professional receive kind of a quick view of the patient's state? We do interventions for patients to help them self-manage their conditions. So we work with stroke patients, diabetic patients, recently also dementia patients. And during COVID, we did some public health interventions. So how can we look at behaviors of people and motivations during this COVID pandemic, and how can we maybe encourage sustainable behavior change? So a bit about this. So really, like I said, we want to share kind of our group work to see if there are any commonalities and hear about from you if you face similar kind of challenges. So just to put things in context, any innovation or most innovations are in the middle of kind of this three main criteria. So feasibility, kind of more the technical aspect. Can we do what we want to do? For example, now we're doing kind of a decisions for a diagnostic decision support in Africa to detect malaria and infectious disease. Can we actually do it, right? So is it feasible? Is it technical? And of course, the viability, the business aspect, will it be cost effective? The business model, and of course the desirability, the human aspect. And we all know that, you know, the three are needs, you know, we need all the three together, because many times it is feasible, it is viable, but people just don't use it, right? As we know. So this is kind of our focus, and we talk a lot about a human-centered design. So starting from the human versus technical or technical-centered design, that we focus on the technology. But again, we start from either point, right? So sometimes we know we start from the AI, right? Wow, AI, can we use it here, 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 and here? Or we have a sensor, a very cool sensor, where can we use it? And then kind of we look at what can we do with it? But we mainly try to start focusing kind of from the human-centered design. What are the needs? What is the real problem? And then can we design an intervention? So I'll show a few kind of projects and tell you a bit about the process. The first one, I like it. It's quite old now. It's 5-6 years ago, but it shows in a nice way, I think, the process. We did kind of the human-centered process, and then the others I will go much more briefly. So this was a big European project with multidisciplinary, with many universities and research centers. And kind of the main goal, there were many aims, but one of the main goals is to kind of really develop a diagnostic decision support system for general physicians, for GPs. And a bit of background. So diagnostic errors, which are wrong, delayed, or misdiagnosis, are very common and harmful and costly, as we all know. They're also understudied. Some claim that there are 40,000 to 80,000 annual deaths in the US, and they're the main reason for malpractice claims. Okay, yeah, so this is just showed, this is quite recently in 2019. So yeah, 40 to 80,000 deaths in the US. And here it's estimated that 12 million Americans suffer diagnostic error each year in primary care. And if we go to the UK, we see also like 4.3% of reviewed consultation in GP practice have some kind of a diagnostic error. So it doesn't sound a lot, 4.3%, but do you know how many consultations are in the UK per year? In the GP practice alone, around, can you estimate? So a same person can go several times, right? So it's millions. So it's around 300 million consultations in the UK in the GP per year. So 4.3% is quite a lot. Cognitive factors, okay, are the main cause of medical error. So it could be cognitive biases, such as premature closure. So jumping to conclusions, right? Before kind of looking at all the data. Availability bias, that was really significant in the COVID, right? Everybody that coughs, oh my God, you have COVID, right? Affective, like stress and fatigue. Failure to gather information is responsible for most errors. So this pattern recognition, oh, it's probably this, it's probably that. Let's just continue with that. And of course, diagnostic hypotheses drive the search and interpretation of clinical information. So if the GP thinks it's something, they will find the evidence, right, kind of to prove it, like we all do, right? We all have those biases. And of course, diagnostic errors lead to wrong investigations and management. And we see harm. Looking a bit about the context of how the work of GP specifically in the UK. So they see a large number of patients in a day. We know that they deal with a large range of diseases and multiple conditions. So they see babies, they see elderly. Just imagine how many possibilities can be in a consultation. It's a dynamic situation with evolving information. So if someone came 6 months ago and they were fine, doesn't mean they're fine today, right? So it's always evolving. And in the UK, they have a gatekeeping role. So we know that they control access to specialists. And the main challenge is actually balancing the risk of missing a disease, right, versus an unnecessary investigation, right? We don't want to send everyone to blood test all the day, right, just to prevent errors. So it is quite challenging, and we know there's a lot of queues. They have phone calls, people coming in, and they also need to give quite, attention to the patient, and they have only 10 minutes to do that in a consultation. And one of the things I was surprised when I came to the UK, that you can raise only one complaint, right? So if you have a headache and something with your leg, you need to decide which one you're gonna focus on in the consultation. They might be connected, they might not, but it's like a different, 10 minutes, okay, select your priorities. And we know diagnostic decision support system is not something new. It's already like 50 years ago. But still, it's very limited in its use because GPs sometimes don't perceive the need for that, right? I've studied 15, 20 years now. A system will tell me what to do. It doesn't make any sense. So they don't perceive the need sometimes. And it's also the perceived challenge to one's authority as a knowledgeable professional. right? So it's easier for them to get advice or support about memory. Like if they can understand that a computer is better than them with remembering things, right? Because they have a big database. So prescriptions or screening, that's easier for them. But for judgment and decision-making, they don't think a computer can, be better than them. And they also don't think that this holistic way they diagnose patients can be reduced to 5, 6, computer rules or AI. And of course, sometimes they're concerned that their patient and colleagues will think less of them. Oh, you're using a diagnostic tool, you can't diagnose yourself. And of course, it's time consuming, right? There are only 10 minutes, it probably will take a lot of time to use it. So as we know, the challenge with this project was that despite evidence that it does help, right? So the diagnostic decision support systems proved to be very useful, proved to help, and they had good performance. It doesn't, of course, mean that, right, GPs will want to use them. So what will actually motivate them to use such a system? So our goal was actually to understand the decision-making process they do, how they diagnose patients, whether their cognitive tasks and needs, kind of in this scenario, design a prototype, a diagnostic decision support system, which was integrated with the electronic health record. And of course, the aim was to reduce, in general, diagnostic error, but also to increase user acceptance. So they would want actually, to use it. So we selected the method of the framework of decision-centered design. And that's, I will focus on different kind of focusing on centered design, because we said human-centered design, but human-centered design, as we know, is very broad. And in this case, we wanted actually to understand their decision. So we selected this decision-centered design framework, which actually was the first design for firefighters to understand how they deal with this dynamic situation of, just imagine a fire, how it changes and how you need to make decisions on the spot, and translated it to this environment of kind of the general practice. So this framework contains 5 stages. So preparation, kind of understanding the context, understanding how GPs work, what are their main tasks, knowledge elicitation, understanding how they make those decisions. So we use cognitive task analysis, I will speak in a minute, and analyzing the result, designing, the intervention, and actually evaluating it. So in the preparation, we observed 104 actually patients, GPs, I wouldn't say diagnosing, but 104 consultations. So how they do a consultation, how they use the electronic health record, what do they ask the patients, and actually how they manage this patient. So this is just a part of it. We created a hierarchical task analysis of all the tasks that the GP does during. Then we wanted to know how they make decisions. So how can we do that, right? Because we observe that we can't really know what's going in their head. So we used 34 think aloud protocols of GPs actually diagnosing patients, those transcripts, and also interview transcripts about patient cases the GP believe they have diagnosed by intuition. So we had this kind of transcripts of think aloud protocols and interviews, and we analyzed them using the situation assessment record. What does it mean? We took a transcript and we highlighted everywhere where there was either a situation-aware assessment or a decision-making. So we highlight every place where the GP kind of made a decision. Then what we did is we added it. So when we observe, we can see, right, what happens in their head. So these are actually from the cognitive task analysis. When they think aloud, these are the cognitive tasks they use in addition to what we can observe. So we saw that there are 4 main kind of decisions or cognitive tasks that GP do to diagnose patients. So the first thing they do is they retrieve the information from the electronic health record, right? Combine it with what the patient says, right? To gain this picture of the patient's health state, right? So they need, and with their own knowledge, right, of diseases and what could it be. So they have this really difficult cognitive task of having all this information from the electronic health record, from what the patient is saying, and from their database in their head, right, to combine it. Then they start generating this hypothesis. What could it be? They test it in their head, or they ask the patient questions, right? Maybe I think it's UTI. Well, does it burn? Do you have blood? You know, all this kind of red flags. And then they decide on a management plan, which could be go home, rest, come back, right? It doesn't have to be a diagnosis, a specific, but it does have to be some kind of a management plan. So just to give some example, if the first kind of cognitive task is retrieval and integration of information, what we did is, you'll see soon, we analyzed it. So we tried to think what information they need to gain to do this cognitive task, and what could go wrong, and what kind of design solutions we can propose for this. So, for example, retrieval and integration of information, it can be that important information may be missed in the electronic health record, right? I don't know if you saw an electronic health record, it's really difficult to find information there because it's mainly designed to insert information, less for decision-making. So it's quite a translation of kind of the papers, kind of records that we once had. So it's mainly all the information with dates and a lot of text notes. So sometimes they don't see important information, and sometimes they have strong initial impressions from the electronic health record before they start the consultation. So I observed the GP when they kind of consulted the patients, and they look at the record and said, oh, I know her, she'll come with her migraine again. And then this patient comes and said, oh, doctor, look, I have this headache, right? And then, okay, it's her migraine, and almost no question asked, but it could be anything, right? Theoretically, it could be. Yeah, some of the quotes and some suggestions. This was just initial suggestion that maybe we can highlight important things from the past or risk factors in the record, right? So the GP doesn't have really to scroll and see the important things. For hypothesis generation, the main errors could be focusing narrowly on a hypothesis, like, okay, this is COVID probably, and just asking questions about COVID, or this is the flu, and uncommon diagnoses may not be considered, right? If the health complaint can be explained by other causes. So the main sentence of a GP is common things are common. They always say it, right? But because it's right? Common things are common. You can't always think, oh, they're going to die in 2 days. But it's this balance that's very, very hard kind of to get. So what we proposed is based on the reason for encounter, on the reason that the patient comes to the GP, they get a list of possible diagnoses already at the start. So based on the reason for encounter and some information in the electronic health record, they get some possible diagnoses that hopefully opens a bit their mind before they start narrowing down, oh, I think it's that. So can we kind of broaden their hypothesis kind of space, kind of to mess up with their jumping to conclusion kind of process. So then we did an analysis. So this is the full table. We have kind of the decision or the cognitive requirement, what could be possible errors, how it is done today, and what information they need or critical cues to gain this information, and what could be a design solution to hopefully minimize the errors. So we designed a prototype. So based on the reason for encounter and some information, they got an initial list of possible diagnoses. Then they typed the symptoms as they according to the consultation. So the patient says, yeah, I have fever, 38, I have this. They type the symptoms and the diagnosis change accordingly as they type along. And they had also red flags, so they could click on a differential and see questions they can ask the patient. And then we did an evaluation with 34 GPs, once with the tool and once without. Yeah, we fixed a kind of a room, kind of looked like a GP. We had a waiting room. All the colleagues screamed at us that we were doing a lot of noise, but and we had actors as yeah, simulated patients, so actors as patients, but real GPs. And we did find that using the tool did improve the diagnostic without increase in the without increasing the tests they did, so like blood tests and referrals. The qualitative result, we also asked them, so the majority of GPs found it useful. They said mainly that it helped them consider other diagnoses that they might have not considered without the tools, but 50% of the GPs felt that it changed their consultation style. So actually, this could be a very kind of big barrier because they're not used to type during consultations. I don't know if you noticed, if you went to the GP, they're looking at you, they're very sincere. They do, and then once you leave, they type everything in. Some, it depends on the style, right? But 50% do that, and then they felt that they need to write every symptoms if they want the list to change. So some didn't find it. I mean, they said it changed their style, and that would be a barrier for use. So we're still looking at mainly trying to kind of improve the accuracy and the technology of this. Another kind of project, we did a lot with stroke patients, so trying to design kind of innovations for long-term management for stroke patients with multiple health conditions. And this was a bit, or can we say data center design or information center design. So we were curious with all this, wellness sensors that patients have. Will a GP be interested in receiving this information as part of the electronic health record, right? We have their heart rate, we have their steps. And what do you think their first answer was? No, please, no, nothing. Just leave us alone. Yeah. So nobody's interested in data, right? Everybody's interested in knowledge or something that will be meaningful. And we thought, what could be meaningful? Because they said, just imagine, now I get the heart rate of every person, And sometimes it's 180, and I don't know, maybe this guy's running around the whole London, or maybe they're sleeping, or that's terrible. Yeah, so we did some experiment with that. What can we display? But then we had this database of stroke SLSR, which is South London Stroke Register. And we said, what can we do with this information? We have so much information about stroke patients, their health, their diagnosis, what happened to them. Can we ask actually patients or healthcare professional, what can we do with this data? So it was a bit of a weird kind of scenario. We have this data, can it help? So we had actually 53 stakeholders, including patients, healthcare professional, policymaker. It wasn't that easy because we tried to phrase it in a way, right? We can't show a database and say, wow, this is killer. What do you want to do with it? But we tried to understand what could be their needs that this database could answer. And it took them time, but they gave some ideas. And one of the things they were quite interested in is stroke patients have a higher risk, or 40% higher risk to have a second stroke or a third stroke. So how can we prevent that? Can our data maybe provide some information on that? So we try to understand what information the patient need to help them manage better their stroke so they won't have another, to prevent another stroke, and actually co-design or iterative design with them a system. So I'm a bit jumping, but the main themes that they said that they want to for us to communicate the risk in a meaningful way. Because what happens now, they come and say, oh, you had a stroke. Oh, you have a high risk to have another stroke. You know, what is a high risk? What do you want me to do, right? I mean, so what does it mean, right? High risk, but I do, you know, I eat well, I do exercise, can't be that high, right? It should get reduced by now. So can you tell me what's my specific personal risk? They also wanted to compare the individual perceived risk with their actual risk, because some people think it's very high and actually it's not that high, but most of them think they don't have a risk, but actually it's much higher than they think. They want always, patients want personalized things, right? So personalized treatment to help control the stroke risk factor, effectiveness of recommended treatment, because they don't know what happens is they say, we go to the GP, we get this 50 prescriptions, right? And then we could just go to the pharmacy, we take the medication and we just drink it all up without remembering what's the pink pill, what's the yellow pill, you know, and then you say, oh, the pink pill is not really, makes my stomach pain, I'm not going to take it. But that's actually the most important one because that's for the blood pressure. So all the things, they don't have really knowledge how effective it is, and really do they need all this 22 pills or medications. Yeah, address concerns about treatments, support continuity of care, and also maybe identify individual at high risk and alert them. Say, really, you, based on, I don't know, your age, your blood, your this, your that, your type of stroke, you have a high risk. So this is kind of the first versions we had, and they also wanted to be engaged in the decision making. They felt sometimes they're just, you know, do this, do that, take it, and without really consulting them, without really engaging them in the process. So this was kind of a shared decision making tool with the GP and the stroke survivor, kind of showing them the possible treatments and actually showing the risk. We played a lot with visualizing risk. This is one of the more provocative ways I think we selected, because this is actually a queue of people. So we're saying out of 20 people around your age, we think you're number 4, you're the 4th one kind of to have a stroke. But however, if you control your blood pressure, you'll move to number 9. So we just wanted to see, you know, yeah, if they're happy, because today they have the smiley faces. I don't know if you know, like 100 smiley faces and said 20% or 20 people out of 100. So some liked it, some less. Some were really stressed that they're in the queue and they're 4th, and they don't even have, somebody said, I don't even have time to go to the loo, you know, I'm number 4 in the queue. So 9 is better. Yeah, but then it kind of tried to show them, look, you don't have to do everything. These are your options. You can select, you have autonomy, you can control. Just these are kind of what will happen. Do what you can do now, maybe change it later. Okay, then COVID came and we were interested some more in kind of the public health and also the infodemic. There was so much information, you probably remember, that nobody knew anything, you know, what to do. We felt we can't kind of take informed decisions because everybody says something else. Go out, don't go out, put a mask, don't put a mask, social distancing. So it was very kind of a confusing period. And we wanted actually to encourage responsible behavior in this kind of infodemic. So the aim was kind of to better understand kind of the human needs, behaviors, and motivation in this period, and propose guidelines for public health communication. Yeah, that will encourage responsible health behavior while focusing on sustainable behavior change and well-being. So what we did, we applied the self-determination theory. I'll talk about it in a minute, but also other psychological theories, also from philosophy and human-computer interaction. And we also did kind of a systematic review for health communication strategies countries used during this period to see if we can if they adhere some of the guidelines and they're proven useful. Oops, sorry. So the self-determination theory is actually saying that people have three basic psychological needs: autonomy, which is having choice; competence, that you feel you're capable of doing the thing you want; and relatedness, so feeling connected to others. And if we have these three, probably our motivation, or at least internal motivation, will increase. We're more engaged, more willing to do things, and it will help the sustained behavior change and well-being. So we proposed guidelines based on this, and based on the literature, and based on the theories about how can we increase autonomy, like provide choice within kind of all those COVID limitation, competence, like, you know, people need, if they want to get vaccinated, it needs to be very easy to do that. They have to feel capable. They can do social distancing, for example. And relatedness, you know, how can we increase maybe trust, you know, in the guidelines, and transparency, and feeling we're all in this together. So these were some kind of initial guidelines for public health communication. This is how I'm with time. I'm okay. Yeah. Okay. Sorry. So this is the project we just started. And it's about, reducing the environmental impact of operating rooms. So if at first I showed the example, it was kind of a decision center design, then we did kind of data center design or information center design. And in the last two, we're more focused on behavior center design. So understanding how people behave and how can we maybe change their behavior. The motivation for this project was that NHS accounts for 4% of England's total carbon footprint, and operating rooms are 3 to 6 times more energy intensive than the rest of the hospital. And they're a major contributor of waste. So can we actually, why is it really? And we wanted to have kind of a behavioral science approach to maybe kind of try to change behavior of operating room staff, if it can help. And we actually realized there are a lot of guidelines for what operating room staff could do. So there are quite a lot for, using reusable instead of single use, turning off the lights, the anesthesia gas. So there are a lot of things they can do, and they're quite aware of what they can do, but there is a big gap, as we know, between intentions and behaviors, right? There is always kind of this big gap. And we wanted to know if we can do some kind of understand what are the barriers and facilitators for doing that, and if we can change the behavior. So this, just to give some example, we started talking to surgeons and other operating room staff to understand what's going on and what could be the barriers. And one of the guidelines is to use local anesthesia instead of general anesthesia. So you can imagine it reduces, right, everything. So the stay of the patient, it reduces the amount of gas, it's really definitely more environmental friendly. But when we ask why do you use general anesthesia, what do you think are the main reasons for that, and not moving, for example, to local anesthesia? Of course, if the surgery could be done in local anesthesia. Do you know? Why wouldn't they?
They're making sure that the patient doesn't freak out, maybe.
Yeah. Okay, yeah, definitely one of the reasons. Yeah. So so that's one of the things, and kind of following on that, it's mainly, they prefer them asleep. So it's relating to that, right? Because yeah, just imagine you have to pay attention what you're saying, right? I mean, actually, I had a small surgery in my eye like a few weeks ago, and it was local anesthesia. But you're quite, you're not really, you're not like having a cup of tea and having a discussion. But I felt it's like 30 people were on me. I swear. I think it's all the how do you call them? Like the stagiaire, all the practicing students who were in this room. Probably I had a very interesting case or something. So there were a lot of people. And then I heard, oh, Prof, I think said, oh, Prof, I think I did something that you didn't mean me to do. Very politely. And I was like, and then I heard him like doing, don't worry. This is fine or something. And I was dying. My goodness, I woke up and I felt it here a bit. And I woke up and only I had the surgery in 2 eyes and only this was covered. I said, that's it, I'm doomed. Like probably. So just imagine, and they knew I was awake. I think if I wasn't, it was, oh shit, what's going on here, you crazy person. So I mean, this is a really, I can totally relate to that, right? That you don't want to, the patient to be awake. It's much easier. You can say whatever you want. You can joke around. You can tell about your ex-girlfriend, right? I mean, once we're there, and that's their job. They're doing it all day long. Just imagine all the patients are awake all the time. It's quite terrible. So this is something important to understand. Maybe they don't want to change it, and how can we change it? And also, but maybe many surgeons also said, we're just used to it. We do this, surgery for 20 years now. It was always with general instead, changing it now doesn't seem right. Also, the WHO, for example, did research and they realized that 85% of the waste in hospital is just regular general trash, like you can throw it in the black bin. So it doesn't have any infection in it or hazardous in it. However, 80% of the waste in hospital is thrown in the hazardous bins, so in the yellow and black stripes. And that's mainly because of convenience, right? I'm not going to think, oh, now there's this recycling, is this. And also there is still this, we're saving, notion that we're saving lives here, don't talk to me about kind of bins. Although this did change in the last few years. So it was a few years ago, but now we feel this change of also surgeons understanding the importance of the environment, but still, when you're doing the surgery, itself, it's kind of seems less important. So how can we deal with that? Maybe it's something that is easier to deal with than just having the right bin at the right time. That could solve it. So here we're focusing really on behavior-centered design. So how can we support this behavior change? Maybe change the setting of the operating room. We're also using the behavior change wheel. So it's really centered about behavior change in this case. That's it. The last two, we're just starting now, just to say what we are up to. So this is, I just came from Nigeria a few weeks ago. So this is the point of care of diagnostic system in Africa. And this is actually technology-centered design. So we have this technology that was developed at Imperial for different use. And they say, can we use it here for Africa? Will it be appropriate to diagnose malaria and other infectious diseases? So what we're trying to do now is, this was a workshop, understand their needs. We already understand that it's not going to happen exactly with the tool we have. So a lot of changes should be made, but really understanding what they need. This is the technology. Can we meet right in the center? Because we have the technology. We can change it a bit, but probably not a lot, but kind of understand this kind of co-design process with the users. And just to show that we have also students that do more specifically. So she's a new PhD student, Echo, and she's trying to understand kind of empathy-centered design. And I know UCLIC has a workshop, I think, at Kai, empathy-centered design. So, right?
Yes, we do.
Okay, yeah, so you should tell. Yay. Yeah. So I just sent her the link. So she's interested in building empathy among participants with diverse power dynamics in healthcare innovation. So I think it's really interesting in co-design that we have healthcare professionals, we have patients, right? We have engineers, and all this hierarchy and all this powers. How can we kind of design maybe something that improve that? And we actually feel quite a lot in the medical, right, in the healthcare domain, between even nurses and patients and doctors and now surgeons, and how they transfer sometimes this hierarchy from work to the co-design process, and how can we perhaps deal with that. Yeah, so just to summarize, human-centered design is quite, so we all know there's so many processes, and if you Google it, you'll find a lot. But the main kind of attribute is really bottom-up approach, right? Understanding the needs, kind of design, translating to some requirement, design and evaluation in an iterative design. And in research, we have this kind of environment, this bottom-up approach of understanding user needs. And then we have kind of the theory we want to use to make it much more rigor and have this design process of creating kind of and evaluating. But the challenges, I think, are quite a lot in kind of this domain. First, how we accurately capture stakeholders' needs and wants in this co-design process. So co-design is quite, it's a challenging process. And do we have enough variation in the people we ask? Are they representative of the group? You know, how do we make sure we hear everyone that has something to say? So this is quite difficult with this bottom-up approach, but also do we select, because we sometimes do that kind of decision-centered design or information-centered design or technology-centered design, and select some theories that relate to that, but do we use the right theories, or it's such a multidisciplinary field, right? So we can take theories we usually take from psychology, but we can take from philosophy, we can take from social science, we can take from communication, right? There's so many, and marketing, so many interesting and similar things. And how do we select kind of, or integrate the theories to really integrate it in the design process? And we want to contribute to knowledge, right? Of course, as well as a system. And everything we do influence everything else, right? The micro and the macro system. So if we do design a diagnostics decision support system for GPs, it influences how the hospital work and how everyone works. How can we have this kind of general system approach and consider also unintended consequences of our design? So this is just some of the challenges and the work, and thank you.
Thank you so much for that. Questions straight away?
Yeah.
Thank you. Really interesting. I have a contextual question. So you speak in plural, but you didn't, or I missed, if you gave a picture of the group. Because I know some people who are the Dyson School of Design Engineering, but it sounds like you're referring to a more specific subgroup. Can you tell us a bit about that?
Yes, sure. So sorry, I should put pictures, but it's a very new and dynamic group. So this is actually, I'm leading the group. It's the Human Factors in Healthcare group. And we have currently 3 PhD students, 2 postdocs, and 4 master students. And I'm working in collaborations with 2-3 other staff members. So that's currently the group, and we'll join 3 PhD students in October and 2 posts. So, yeah, but that's it. It won't grow much larger than that. Yeah.
Got a question coming online here. I'm just going to read it out. This is from Julia. She says, out of interest, did your team critique existing diagnostic decision support software before creating your own, e.g. Isabel, WebMD, and were there any discussions about legal liability of using DDS?
Legal? You did. Yeah, so definitely the answer is yes, we did. And we even have a discussion with the guy who developed Isabel. And we found that most of them were not, our main aim was to integrate it in the GP process. And the others, like Isabel, you need to stop what you're doing, the electronic healthcare, say, oh, actually, I'm not sure about this diagnosis, go to the other system, enter symptoms, and kind of consult the system. And GPs usually don't like to do that. So what we try to do, it will be integrated as part. So it's not saying now you're using our diagnostic decision support, is that you're entering symptoms, we suggest you can ignore them. So that was the main difference with existing systems. Yeah. Yeah. Oh, sorry.
Thanks for talk. So in terms of like the behavior change side, so there's quite a lot of, you mentioned like the behavior change world, and it's quite a rigid framework to some extent. So how do you reconcile using that type of theory or frameworks with like the design process and approach and frameworks? Like how does that work as like a workflow?
So it depends what we want to do. If we have a specific behavior that is that we can pinpoint, we use the behavior change wheel to know how to do. But in this case, we don't know yet what we want to change. So we're kind of investigating. So we're using a broader behavior-centered kind of design approach. So it's understanding first kind of the barriers and facilitators, what are the general kind of behavior. It also talks about behavior settings. So what are the settings? And maybe, so one of the researchers, recent research talks about that if we know the setting, the design setting of a specific space, we can predict behavior in around 90%. So they did this in schools, for example. So if I design a classroom in a specific way, I will know how the child will behave when they're entering, like what did they play first, what they do after. So these are some of the things we're exploring. We just started a project now about looking at the setting of an operating room and seeing if we can change something in the setting, and that will change behavior. So you're right, the behavior change wheel is, yeah, it's very specific when you know what you're doing, but first we're more exploring different kind of methods and theories before that. So just one example, we also look at nudge. So, with food, right? So in schools, they wanted to improve the health of children. So they put first the fruit and, when you come, you can find the chocolates, but first is the fruit. So to kind of make it more accessible. And then if you want the chocolate, you have to go to, a bit farther. Okay, it's not in the counter. So we're trying maybe to think about these. Maybe you have the reusable equipment first, but if you need to use the single use, you could, right? We can't prevent surgeons unless they tell us we can, right, to use something, because we don't know what will happen in the surgery, right? We can say, oh, you don't need the single use, don't worry about it, everything will be fine, right? So kind of we're just now exploring different theories, like the nut theory or behavior, like that we can use. So that's the first stage we're doing now.
Thank you for the talk. It was very interesting. So I have a couple questions. Hope that's okay. So first about on the study with the GPs. So when you come up with the cognitive task analysis, and you have this really nice table, so are those coming from both interviews and observations, or is that the only thing that we did to understand?
No, so the cognitive is just based on. So we had a different study of. We talked with GPs had to diagnose simulated patients.
Mm-hmm.
We gave them a case study, 42-year-old male, came with and then they had to diagnose them. So they asked a question to a researcher who was on the phone. They said, well, okay, so the researcher had predefined prompts, so everybody will get the same. So the GP said, do you have fever? And then the researcher put the sentence 37.8, right? If the GP asked the question that wasn't, there was a standard saying, I'm not sure. Okay, so that was, so we transcribed this process of diagnosing assimilated patients, and where were the decision points. So that's
Okay, thank you. And follow-up question from the same study, the GP ones. So so when you show them the different diagnoses, from your system that you're proposing, where were you getting those diagnoses from?
Yeah, that's a good question. It was a bit, so it was mainly from, so we worked with a statistician. So it was mainly according to the systems he designed, he ranked the diagnosis that could be based on the symptoms. So for example, fever and headache or abdominal pain, these are the main kind of probabilities that these are. So we did a combination. So one is the probability that you have these diseases, and what he did is another thing is to put uncommon diseases as well in the list. So it was based on probabilistic, what's most probable to be based on the symptoms and the information in the electronic health record, plus uncommon diseases that could be.
And this is from databases in the UK. Is it like the probabilities out of?
Yeah, it's probabilities of diseases that are known based on literature.
Okay. I mean, if I can ask one more thing, it doesn't matter. So on the OR, like the behavioral change study, so you proposed like a couple of ideas in which the surgeons could potentially, prevent waste, but do you have an idea of how much of those actually translate into like decreasing a significant amount of waste?
Yeah, that's a very good question. A lot say actually behavior change is not the right way to go. It's policies, is procurement, is buying things, and we know that, right? But I think at the end of the day, it will be a combination of all, and we're focusing on behavior. So there are some behaviors that are more meaningful, like using gas, the kind of a more sustainable gas in anesthesia. So that's one of the main things. Electricity is a big thing because the lights are always on, the machines are always on, the heating and cooling systems are always on. So we know hotspots. So we first identified kind of the main hotspots. Doesn't mean that it's easy to change behavior in those cases. So that's what we're trying also to do, is trying kind of to have now a mapping of the main hotspots and what could be a good balance between a meaningful contribution, but that can be changed with behavior. But definitely behavior is not probably maybe the most significant way to influence, but yeah, it should be a combination, right? At the end of the day, the people that do the work need to consider their options and select probably the least damaging one if they can. So we're thinking about color coding and all this, but yeah, that's one of the analysis we do. So there is kind of lots of analysis of what are the main hotspots. We're just going to try to change the behavior in those if possible. Thank you.
Yeah, so thank you very much for a super interesting talk. I want to maybe share something or ask at the same time, maybe some recommendations. So in my personal experience, doing co-design with physicians is rather difficult because, as you also mentioned in your talk, they are used to a certain form of work and they are not really open to new changes. And there's also a factor of ego that plays a role in that.
No, really?
Which I was wondering, like, do you use certain techniques in co-design sessions or workshops with physicians or specifically surgeons to design new technologies or systems in a creative way to let them think outside the box a little bit.
Yeah. We do. I mean, we do have cars. We do try to be creative. To be honest, what the best thing that works is having a surgeon as a facilitator. And that's what we did last time. Speak their language. I mean, because if we bring them with us, right, they're part of us, we engage stakeholders really throughout the whole project. We're not just saying it in writing the proposal. So we have 3 dedicated surgeons in our team, and they're doing actually the work. We're doing the work, but they're
Right.
the face, and it makes a big difference, because I see how they, yeah, if someone like human factors trying to say something, or a surgeon saying something, in this case, not in a bad way, but they just more relate to them and really open up. And then we have the designers that a bit try to throw creative words, kind of open up. But again, I think, I don't know, if there is a change, but yeah, but some are much more open than others. So, yeah. And that's another issue. Do we take only the ones that are open to change? You know, it's quite never ending to know what's the right thing to do.
Yeah,
Okay.
Initiatives.
Thank you. Thank you, Talya. That was an excellent, very thought-provoking talk. And I have lots of things I could talk to you about, but a couple that I wanted to ask you. One is with the GP study. So what would be like the next step? One of the things that you said was a problem is like things like stress and being under time pressure to diagnose things and so on. So I wonder, how much do you think like the fact that they did well, or they found the system acceptable in a simulation, was that they were just not under the kind of pressure where they weren't afraid of making the wrong diagnosis, right? It wasn't going to kill anybody.
Yeah, although they started feeling like it's real. Like one in the scenario, one of the actors had to say, "I'm smoking," right? That's the kind of character. Smoking, you shouldn't smoke. Yeah, and that's what like the GP later went out and said, "You shouldn't smoke," and he's not smoking. I mean, it was quite confusing because they were really good in the display, and that's what they do. So it was quite confusing. Yeah, sorry, but yeah. So what was the question?
No, I relate to that because I've done some simulations, and it does happen, is a blurred boundary. But
yeah.
I mean, how do you think this would, like, what would be the next step? What would be the next study?
We had lots of hopes, but yeah, some of them didn't turn out. I think now the main project we have now is kind of improving the system, because as I said, it does based on probabilities and things like that, but it's not really, you know, not sure, it's not accurate enough currently. That's one thing. The other thing, I think, as long as it doesn't, they don't need to change a system and it just is displayed there, they don't have a problem with that.
Right.
And they don't need to relate to it. They don't have to use it. It's just there and it changes and they can peek on it. I think it could work in this case, because it didn't work when they had to do something. They will not acknowledge, it's hard for them to acknowledge, oh, I don't know what to do. Now I'm going, it's like, it never happens. Oh, they prefer sometimes to go to a colleague and say, look, can you come for a second? I have this, you know, but we saw that they kind of liked it at the end, just peaked. They said, I didn't really use it. I kind of peaked. I saw that I'm kind of in the right track. And then when the system proposes something they didn't think about, they do enter and say, ask the red flags just to make sure it's not. So I do think there is it could work. Again, we're not replacing. It depends also how we market it. It's definitely not replacing, just kind of opening or giving. Because, right, we're limited in our memory. How many diagnoses can one have? 4 or 5? The system can have 100, 1,000. So they know that. So if you don't say it's replacing your judgment or decision, it's just proposing. It's a stupid system. Proposes kind of differentials that you may want to consider.
That's interesting. I mean, as a probe as well as to what might be useful in that consultation, right?
Yeah.
Can I ask you a quick follow-up question also about the second study,
Yeah.
Which is interesting again, because you're talking about how you can communicate data to healthcare professionals. And there have been studies in the past as well. I think one of the big ones was the Monarca study, and with Bardrum, Jacob Bardrum and everybody, where they sort of did this huge study with people who had bipolar disorder, if I remember right. And then the whole thing was co-designed with surgeons, well, not surgeons, sorry, with doctors. And later they just, even though they had co-designed the system, they did not get traction, even though the visualizations were exactly what they needed and all of that. They just did not have the time to look at all of this data that the patients were generating. So
Yeah.
what do you think is the sweet spot?
Yeah, I teach part of human-centered design to students. And I say, it's important to gain, the understanding what user want and need, but it doesn't mean we take everything they say, right? So that's why I think the theory, that's why we're doing research. The theory is very important to take things that are already validated and already are working and combining it. So yeah, it's challenging. So we do want to understand the context. I think it's super, super important. That's why, like, we went to Nigeria. This was my first time in Africa, and all my perception were wrong. Like, everything was just collapsed. It's totally not what I thought. Really, it's like, and I thought I was like open-minded and modern, and so no. So it's super, I think, understanding the context, how they work today, what are they doing, what are their thoughts, it's even more important than what they think they need, because we don't know what we need, right? Unless it comes to it and say, oh, well, we didn't talk about it. Yeah, and this famous, right, like cars, if we ask users, faster horses, and it's exactly the same. So we don't know what we need, but we know our problems, right? We definitely know what our problems, we know the context. So now having these two, can we use theory? Can we use our kind of the co-design process? Can we use brainstorming to think what would really work? But yeah, there's no guarantees, right? Never. Yeah, we don't know.
So last question from the room. Thank you.
Thank you very much for your wonderful talk. I really learned a lot. I'm very interested about human system trust. Human system trust. I think you already talked a lot about your design process, but could you talk more about the trust design in your process? How do you like your patient trust your decision support system?
Increase trust in the system. That's what you mean?
Yeah.
Yeah, it's super important, right? Trust. I mean, that's what one of the things, if the GPs don't trust the diagnostic system and they think it's stupid, it's not going to work. And there was also research saying that healthcare professionals and patients trust more systems that come from prestigious universities than unknown universities. So if we say, and now actually people do surveys about vaccines, if there's different, if it says on the vaccine made in UK versus made in, I don't know, another small countries, or so, like made in UK or US is, wow, that should be super, yeah, who knows what they put in there. But that's super important. And we saw it in the COVID when we did the study that people don't trust the government. And if people don't trust the government, I mean, some countries even more than others, they don't follow, right, the guidelines. So how can we increase? So trust is super important in everything we do, right? If people don't trust, and now we're talking about AI. I know most of you do things relating to AI, transparable AI. So we use those methods actually to help, right, GPs trust the system. And for here, we also thought once we can show this data, show how accurate it is, show, history of how valuable it is or how it contributes, you have to do that. Yeah. So there are different ways and methods to increase trust. And one of them is transparency, as we know with, governments, when you feel they're hiding or they have personal interests, right? Use this. Why? Why should I use it? Did your mother design it? But yeah, so we also relate to that. But sometimes this was kind of a preliminary stage. So we didn't even ask about those questions, but usually we do ask and see what we can increase that. Yeah. Because trust in the system is one of the main reasons people don't use.
Okay, thank you.
Yeah.
Well, thank you once again for
Thank
coming
you.
and visiting with us today, presenting your research.
Thank you. Good pleasure.
So I think